Hi there, I'm Nina Davis. I'm a clinical system pathway development lead working in long-term conditions, and I work for Leeds Community Healthcare NHS Trust. And I've been asked to talk through some of the work that we did around the mapping around the support for people with long-term conditions. Now, one of the reasons that we did this work is that we just really wanted to identify where support was and wasn't provided across the whole of the system for different long-term conditions, and whether it was the same for one long-term condition to another. And we took it from the lens that if primary care needed support and they utilised all the services available to them, what else was out there, and more from that medical perspective as well. So what we did is we looked at different long-term conditions, the core ones that were of interest when we were looking through that data. And then we started to look at whether there was advice and guidance out there, so kind of those mechanisms where you can still keep care local to home, but is there a wider access? If you're struggling with something, can you ask for that help? And then along the lines of self-management, which is part of those long-term plans, is there structured elements of advice out there for people? And then what care was provided in the community services and what was provided in the hospital? And hopefully by mapping this, it was giving us an opportunity to reflect, whether it be on some themes, some patterns, how well we were addressing proactive care, and perhaps how we could work differently to achieve that coordination of care. So I'm going to go through all the different long-term conditions and give a little bit of a high-level overview. You may want to stop this recording and have a little bit of a chat and then continue to play it. It's your choice. Okay, but let's start with a little bit of an introduction and a story to go with it. So one of the key aims of why we're wanting to work in a different way as part of these neighbourhood models is we do want to be more proactive, we want to be effective, responsive. And for us to be proactive, we do need to understand risk, those patterns over time. We need to be anticipating what will happen before we have that crisis. And then we need to be acting early so that people stay well. Now, when we've started to look at data within Leeds and those patterns so that we can start to predict things, we have looked at, age at diagnosis, and what's the average age and how prevalent are these diagnoses at that time. And as you will see, quite early on, people are diagnosed with asthma and depression. Going into the 50s, it's more likely to be things like diabetes and arthritis. And then into the 60s, it's more vascular related. So coronary heart disease, COPD, PAD, peripheral arterial disease, or stroke. And then a bit later, we get things like chronic kidney disease. And that starts to tell us the progression of people's health as they go along. And it may start to tell us where those opportunities are to start having conversations. Is it around the time when people might present with depression or arthritis and they may not be doing as well with the mobility? Might that affect their mood? Might it affect their vascular health because they're not as active as much? And it's trying to start to understand those connections between the different conditions, because we know that there are connections between them all. We've also looked at data within Leeds, and I just need to say that this data has been taken from 2020. We've done much more than that, but it's really just to say that we do know that the diseases cluster. So say, for instance, it's that the prevalence of asthma and depression is high. And then the second most common condition tends to be things like diabetes, arthritis. And then when we started to get into the third condition that is more likely to be diagnosed, again, still arthritis, but we're starting to get other things like COPD and cancer. And these are the top 10 clusters that will tend to happen. Now, when we originally collected this data, obviously asthma is high. It's possibly over-recorded. And it just goes to show that if the recording is there, it will get picked up on. If something is under recorded, it won't get picked up on. And perhaps one of the things that we didn't do within this data set at this time, back in 2020, is we didn't look at the prevalence of hypertension. And I'm sure that if we did, it would start to come up in the data. So it brings me on to the next slide of hypertension. And I'm going to call this, as it is known anyway, is a silent condition. And it's interesting because when we start to look at the support that's available out within the system, this is very much a condition that is managed within primary care. But if it's not managed well, it then has repercussions elsewhere in the system. It may affect kidney health, heart health, and just general vascular health. So we don't really have that structured advice, structured for both professionals, for people living with it, and we don't have particular specialist services either within the community or hospital. It's similar for people with peripheral arterial disease. Again, arguably a silent condition unless you're living with intermittent claudication or a wound. Just to put this into context, around about 30% of people will have peripheral arterial disease if they're over the age of 60. 30% will be living with peripheral arterial disease and perhaps don't really know about it. This is also one of the conditions that isn't really coded enough because we don't detect it enough. But still, same story as hypertension. Little is out there until it starts to happen as what I'm going to call an event. So care is available if someone's living with diabetes and peripheral arterial disease. We would monitor those high-risk feet. And certainly if they started to get an ulcer, we would manage it either in a tissue viability service, podiatry service, but also when things got serious, perhaps in the what we call the diabetes limb salvage service. Moving on, arguably again, silent condition, is that this again can go undetected. Community services would pick it up. So this is a regular heartbeat. So what we would be doing here is we would be sort of identifying it and letting primary care know. And there are referral pathways, there are anticoagulation pathways, and but yet there is no structured education available for people with atrial fibrillation. There are online resources, etc. And then finally, chronic kidney disease. And we've done a lot of work in chronic kidney disease, and particularly in the Hatch area. And as a consequence, we do have a lot of resources available, either on these health pathways, within the general practice information point, and more recently on the Leeds community web pages as well. But still we need to get that information out there so people do feel more confident. We do have access to structured education, but equally there is no specialist service within the community. Again, we would be there if CKD was a complication, say with diabetes or with peripheral arterial disease, and certainly if people's kidneys were failing, then that's when we would have the renal service available. Now, I think the main thing that I wanted to highlight from the things that when we did this mapping exercise is if we have these relatively silent conditions, we don't actually offer people that structured self-management support. And there's a lot of interplay between these, in that we could approach diet, exercise, smoking, alcohol, etc. A lot of these things may slow the progression or prevent things worsening and developing other conditions. And it'd be probably really prudent that we do more here, knowing that these are some of the conditions that happen first, and then play into a little bit later to some of the other secondary conditions that happen. If you want at this point, you may want to stop and have a discussion about that. But next, I'm going to talk about diabetes, and just to very quickly go through this. Obviously, we've got type 1 and type 2. Both are very different conditions. Type 1, you need insulin, and type 2, you don't necessarily need insulin, but you might need it a little bit later on. But what we have found out with this mapping exercise is that we do have lots of support. Clinicians, healthcare practitioners can access email advice and guidance if they're stuck, if they've followed the pathways, the guidance, and not quite sure what to do. People have access to structured education. We have face-to-face sessions, online virtual sessions, and also access to apps for certain types of populations. And knowing how important it is, there is also peer support groups for people too, for both type 1 and type 2. Now, the main thing we need to understand around type 1 and type 2, the actual diabetes service element, there is no provision for type 1 in the community. It is a hospital-based condition, if you like, but the complications of diabetes, such as high-risk feet, those would be seen in the community service. It's only until someone with diabetes has an ulcer or an infection or what we call Charcot foot that they would be seen within the hospital. And just to add, for type 1 diabetes, we also have a care line, which means that both people and healthcare professionals can access that line if they're under Leeds Hospital and they have a query, they can get that answered there and then, which is really helpful for people. And essentially, anyone with diabetes, if you need to make a referral because they've reached that criteria, you just complete one referral form. It's a single point of access and it's managed from there. And it's a very similar story for type 2, and I won't go into a lot of detail. Okay, perhaps I do want to pick up that the type 2 diabetes population, because this is a preventable condition, yet perhaps not prevented enough, perhaps, this is a growing population in Leeds. And as time goes by, the ability to manage this effectively is actually quite challenging because the growth exceeds the funding available. What I do want to bring up, particularly to your area, is that Leeds City Council Public Health have done a health needs assessment. And as a consequence, we do want to have a focus on both employment, but also gestational diabetes. Now, in the Hatch area, there is a high prevalence of diabetes, but also gestational diabetes. And having either diabetes or gestational diabetes will put that mother at risk of a high-risk pregnancy. And if somebody has gestational diabetes, the challenge is within the next 10 years, there's a 50% risk of acquiring type 2. You acquire it when you're young, it ends up with more significant problems. It tends to be a more aggressive diabetes. So we want to tackle this. Still very much in the working up phase, but we do know that we want to have a focus on identification, whether that be identifying that women do have gestational diabetes in pregnancy, and that needs a glucose tolerance test, but also that people do get annual tests if they've had gestational diabetes, because as soon as we know, we can get them on the right treatment. But it does also have an element of planning for families safely, taking folic acid, only getting pregnant when it is safe to do so, and also considering contraception. And because of the two topics that we want to look at, both employment and gestational diabetes, we are looking at intersection. So at this moment in time, if somebody is seeking like an employment conversation, there would be very little about how are you going to keep yourself healthy so that you can still maintain your earning potential. Right, so when we start to look at the mapping of self-management, we'll come on to it a little bit more again in a bit. But essentially, if you look at diabetes, we have perhaps the best support available of all the long-term conditions, yet it remains our greatest challenge. And I suppose the question is, why does that happen? I'll come on to the other conditions in a bit. So I'm just going to very quickly go through the remaining conditions. And as you'll probably guess, these are symptomatic conditions and conditions that can, to an element, be rehabbed. Obviously, there is a lot of medical management for it too. And they tend to happen as events as well. So that means that they will be an unplanned admission, obviously quite a costly one. But then once it's managed, people come back into the community and people generally live their lives. Whereas if you have conditions such as chronic kidney disease, peripheral arterial disease, these tend to have a greater impact on people's quality of life. Still unplanned admissions, but sometimes even longer stays in hospital. So there's a little bit of a challenge between the two types, if you like, of conditions. So we have heart failure, and there is cardiac rehabilitation, excuse me, for these people. We have online support through the Heart Failure Academy. So I would encourage you to have a look at referral criteria, and if people meet that criteria and you feel that they could benefit from some help, excuse me, do refer them on. We obviously have a hospital stroke service, and when they're ready to be discharged, we'll refer them back into the community, generally for 12 weeks of care. For some people, we do offer a little bit more through the community rehabilitation service. We are starting to build up good links, like a self-management page called All Things Stroke, and we have good sort of a third sector representation in the world of stroke as well. Similar, it happens for coronary heart disease, and again we have cardiac rehabilitation for that. There are factors as to whether someone is safe or not safe to have cardiac rehabilitation. But again, as I said before, please look at the referral criteria and refer people if you think that would be helpful. And the same goes for chronic obstructive pulmonary disease, or COPD. And for this, we offer pulmonary rehab as well. So again, we find people perhaps aren't referred soon enough for pulmonary rehab, and it would be helpful if people could come sooner. You get generally better outcomes. Right then, so again, when we've started to look at the mapping, we are finding that there is a greater focus in COPD, heart failure, stroke, etc., is that there is a greater focus on rehabilitation and symptom management, which of course is needed. But it's interesting when you look at the mapping, there is sometimes not enough that may need to happen prior to this. And obviously we can't say who or who isn't going to get these events, but we could start to sort of preempt there are certain people that are more likely than others. So I'm going to finish around basically conversation starters, knowing what is out there from specialist services. Do we feel as a system as a whole, do we have that right balance between proactive and reactive care? Which self-management offers would you reduce, or what do you think would reduce the burden on primary care? And those may be available now or they may not. And what sort of primary prevention would be really helpful, and what could be integrated? Because there's a lot of golden threads that come through, and could we sort of optimise on that? So I hope that's been helpful. And we do have an actual Word document. I'll let you read through it. My email is on the slides, the first slide. So if you have any questions, please do get in contact. And thank you.